Thank you. So with immense pleasure, the Department of Microbiology and Immunology, College of Medicine and Health Sciences extends a warm welcome to our renowned guest, the distinguished Professor David Livermore. It's indeed an honor to have you with us today, sir. We extend an equally warm welcome to our esteemed experts, as well as valuable leads from Oman, India, Pakistan, Saudi Arabia, United Kingdom, and Iran, as well as some guests from wherein. We warmly welcome our honored experts and leads from Ministry of Health and Central Public Health Laboratory, Oman, as well as distinguished faculty from the College of Medicine and Health Sciences, Sultan Qaboos University Hospital, and last but not the least, residents from all our centers. Many thanks to respected Dr. David Livermore and all our esteemed guests for giving us your valuable time. Professor David Livermore has enriched the world with a staggering 500 plus profoundly thought-provoking publications which cover the entire gamut of bacterial resistance. He has pioneered research on antimicrobial resistance in a veritable plethora of microorganisms and has enriched the world with his meticulous, painstaking research. His work has influenced several generations of biologists and clinicians alike. He is currently leading an important multi-pronged, multi-centric study called INHALE, which will have far-reaching consequences as it studies the utility of molecular diagnostic tools in leading to better patient outcomes, promoting antimicrobial stewardship, and cost saving in HAP and VAP patients vis-a-vis the conventional lab practices. Dr. David Livermore began his illustrious career in 1980 as research assistant at the then London Hospital Medical College, writing a PhD on the side, as he says. By 1994, he'd risen to senior lecturer in medical microbiology. In 1997, he moved to Public Health Laboratory Service, now Public Health England, swiftly becoming director of its antimicrobial resistance monitoring and reference laboratory. He remained there until 2011, when he transferred to University of East Anglia as professor of medical microbiology. Across 40 years, he has belonged and then led teams that have defined the evolving epidemiology and molecular nature of antimicrobial resistance. He regularly appears on Clarivate's most cited list, has edited for multiple journals, and has served on God knows how many UK government advisory committees on antimicrobial resistance and healthcare infection. Now working part-time for University of East Anglia, he also consults widely for the medical industry on antibiotic development and rapid diagnostics. His is a multifaceted personality. Walking is one of his great passions. He has fantastically walked the entire 3,000 England and Wales perimeter, as well as half the East Scottish coast. In fact, he just returned from the mountains yesterday, and I'm so happy he's here with us today. I hope, sir, you enjoyed your sojourn thoroughly. I do know he was working there, even though he had gone for a well-earned break. We are extremely fortunate to have him as a patron of our study, which is entitled A Multicentric Study to Promote Antimicrobial and Diagnostic Stewardship in the Management of UTI, an experiment in mentorship to expand the One Health concept, which has been nicknamed DASH to protect antibiotics. It was Dr. David Livermore's idea that we give it a name, so I hope you like it. This is the first time Dr. Livermore will be interacting directly with our leads, and I'm really thrilled about it, and I'm sure they are as well. With him steering us, we will undoubtedly go from strength to strength. I'm forever indebted to him for agreeing to be a patron and for so generously offering to take a talk for all the participating centers and the host institution. Before I request Dr. Livermore to take his talk, I would like to tell the leads and members of the audience to please type your questions in the chat box as they arise. Dr. Livermore will address them subsequently. Ladies and gentlemen, it's a great privilege for me to invite Professor David Livermore, the celebrated microbiologist, the microbiologist par excellence, to deliver his much awaited inaugural talk on the troubles with UTIs, surveillance, sequelae, and a landscape changed by COVID. Professor David Livermore, it's my honor to invite you to take your talk.
Well, thank you ever so much for such a kind and fulsome introduction. I must say I barely recognise myself as such a wonderful person, but it's extremely flattering to hear it. So thank you ever so much indeed. Now let's see if I'm technologically competent or not. On the immediate test, no, I'm not. I'm not looking at my screen there. Let's get that down. Let's have another go at sharing this. One moment. That's better. Except that we've now got the last slide rather than the first slide. One moment, we'll have the first slide and then we'll roll. Ladies and gentlemen, you see one other feature of my character. I'm technologically incompetent when it comes to Zoom talks, but now we have got the right screen. So let's roll. As has been said in the introduction, I now work part-time for the University of East Anglia. Otherwise, I do a lot of consulting. Needless to say, this talk is in no way product related, but it is fair that you see a list of my various commercial involvements. I consult widely. The principle's simple: sleep with everybody, fall in love with nobody, which isn't a bad recipe for objective honesty. And with that, let's turn to urinary tract infections. I hardly need to say to this audience how common they are. Over 150 million people have community onset UTIs each year. 8 million presentations in the United States to physicians. A third of women have had a urinary tract infection by the age of 24. The great majority of these infections due to E. coli. So vastly common, mostly in women, mostly E. coli. But a few key distinctions to draw, which will be immediately familiar to every medic in the audience. We have to draw a distinction between lower UTIs affecting the bladder and downstream, and upper UTIs, which are more serious above the bladder, ascending towards the kidneys, potentially giving a pyelonephritis. We have also to distinguish between complicated and uncomplicated. In general, ascending upper infections are complicated, but it's also possible to have a complicated lower UTI. For example, if there's some obstruction to the lower urinary tract, which makes the infection harder to clear. I'm mostly going to concentrate in this presentation on uncomplicated lower UTIs because of their sheer numbers, their frequency, and the fact that resistance is becoming a greater problem. And I should say at the outset that uncomplicated lower UTIs, for obvious anatomical reasons, they occur predominantly in women, not in men. Most of them are painful but self-limiting, but a few progress to something more serious. And that, in a way, is one of our great concerns about UTIs, is that they are the source of many bacteremias, particularly with E. coli. And I put up the slide here for UK data showing numbers of bacteremias, bloodstream infections due to E. coli in England alone, which has a population of about 48 million now in England. And what you see immediately is that the numbers have gone up over the years, and also the proportion of bacteremias due to E. coli has gone up over time. It now accounts for about a third of all bacteremias, and of those, we know the source, be it gastrointestinal infection previously, or intra-abdominal infection previously rather, or urinary infection, or whatever. We know the source in around about 85%. And of that 85%, 51%, so around about 60% of the 85, the source is a prior urinary tract infection. And most of these folks who've had a UTI that seeded a bacteremia have had healthcare contacts. And if you look at their E. coli's from the blood, they tend to be very resistant, more resistant than the ones that you would be seeing directly from UTIs. So that underscores our concern about UTIs, a fear that prior UTIs from difficult, resistant E. coli strains are seeding bacteremias, with a result that the problem E. coli in bacteremias are going up. Not just us, these are bacteremia studies from around the world, predominantly from around the developed world, Scandinavia, New Zealand, United States. And what you see is that the incidence of bacteremias due to E. coli is trending upwards. Look at where the midpoint estimate is on these from 2009 through to 2017. The one with the red circle there is the UK surveillance, so well in this trend. And those bacteremias, E. coli bacteremias, seeded by E. coli are significant. Mortality, a range of estimates, midpoint estimates, anywhere between 10 and 20%. The UK estimated about 18%. So most E. coli bacteremias, trivial, but a minority ascend, seed more severe infections, bacteremias, which are a growing problem in the UK and worldwide, with significant mortality. So let's go back to the urinary tract infections. And the first thing to note here is that while we have good international, at least good national surveillance of bacteremias, we have extremely poor surveillance of the UTIs, which are the seeding source. With masses of UTI data in hospital and laboratory information systems, but the lab that's recording the data tends to know if they were community or hospital UTIs. You know where your patient is, or at least I hope you do, and you know whether the specimen was a catheter urine or a midstream urine. But you don't know very much about the doctor in the community sending those urines to you. Does he or she send a urine from every patient who presents with a urinary tract infection? Or do they only send from the ones who failed a primary empirical treatment? If they only send specimens from the patients who failed a primary empiric treatment, let us say with ciprofloxacin, then you tend to get a biased sample of more resistant isolates going through the lab. And I'll show you direct evidence of that in just a moment. You tend not to know very much about the patient's risk factors. Have they had recent antibiotics? The physician knows that, but you at the laboratory tend not to. Have they traveled recently? Again, the physician might know, but the lab generally doesn't know. And as I've said, there's that two sets of distinctions for UTIs: complicated, uncomplicated, upper, lower. The physician knows, the lab doesn't, and very, very often the lab's information system doesn't talk very well to the system that the physician is using. And you get data like this. Hospitals should produce this sort of thing. It's a little card from University of Rochester in the United States, describing susceptibility of what it calls adult community urine isolates. And this little card is available to every community physician. And you don't need to look at it very hard to see that something is seriously wrong with it. 567 E. coli, and when I add up the other gram negatives, they come to about 400, and then we've got about 300 assorted gram positives. So E. coli is only about 40% of the total. If we were looking at a proper random sample of of UTIs from the community, E. coli would be up at 80%. This is a biased and loaded sample. No doubt a more difficult patient, patients with a community infection who've ended up at the hospital because they're difficult. But because of that, you really can't trust too much the susceptibility rates. There are also some other peculiarities here. Look at Proteus mirabilis, 81% susceptible to ampicillin, 23% susceptible to cefazolin. I can't believe that. Not biologically possible. Now, this is a bit better. It's far from perfect, but it's a study I was involved with. This recruited consecutive women's urines. It didn't recruit the consecutive women. It recruited consecutive urines from community women going through laboratories, 20 centres across Europe plus Russia. Recent looked at E. coli only and prevalence of resistance. So you see immediately very high rates of resistance, 30% to trimethoprim, over 50% to ampicillin, around about 18 to 20% to cephalosporins, coamoxiclav, and less than 10% to nitrofurantoin, phosphomycin, mesillinam. And I put it to you that these sort of data suggest that in these places you should be preferring an antibiotic in this group, nitrofurantoin, phosphomycin, mesillinam, to one in this group where you've got substantial rates of resistance. But as I'll come back to, these preferred drugs have problems. But let's stick with this issue of surveillance, because it only gets worse. That study I just showed you did at least look at urines from women, community, mostly should be uncomplicated, and it recruited consecutive urines. This one goes a step better. It's a few years old now, but it recruited consecutive women presenting to a series of 23 what we would call general practices, community practices in Gloucester or Norwich, 2 places in the United Kingdom, in the other words, who had a clinical diagnosis of cystitis. Excluded recent prior UTIs, excluded upper UTIs, excluded pregnancy, excluded very recent antibiotics. And a urine was taken regardless of whether or not the physician would have ordinarily sent a urine. The patients were all given trimethoprim at the time. I don't think that's quite appropriate now, but at the time that was what was done. There was a clear definition of what bacteriuria was and identification of susceptibility testing of the bacteria was done. Ended up with pure cultures from 317 patients, and 85% had E. coli. That's the sort of proportion you expect, and compare that for a moment to that proportion of about 40% from the University of Rochester's little card going out to confuse local community physicians. Now, if you looked at E. coli from the community routinely going through the Norwich and Gloucester labs, you would think that trimethoprim resistance was about 25%. But when you looked at these consecutive urines, it was down at 13.9, 14%. The point is that the physician's normal practice was to give these ladies an empirical round of trimethoprim or whatever. If they were cured, end of story. If they weren't cured, only then did they send a specimen to the laboratory, which means the lab gets a biased sample in the norm case of things. Once you go to testing consecutive women rather than consecutive urines, you see a very different pattern with a much lower rate of resistance, almost half what the lab, or a little bit over what half the routine data would tell you. On the other hand, the study, and remember these women were given trimethoprim, if they had a resistant isolate, they were much more likely to reconsult. So resistance mattered. They were more likely to receive a subsequent round of antibiotics. That's not surprising, but it's still significant. And treatment was more likely to obviously fail. So in the normal way of things, resistance was being overestimated, but resistance matters clinically. Now, this was a few years ago. The rates, no doubt, are different now, but I'm sure the principles still apply. This too is an old study done by Peter Davey and his colleagues up in Dundee, and they looked at risk factors for trimethoprim resistance. So if the odds ratio is above 1 and the confidence intervals don't overlap 1, then it's significant. And look at this. The more trimethoprim prescriptions you've had and the more prescriptions for other antibiotics you've had, the greater the risk you've got a resistant isolate. So patient factors matter. Here's another patient factor that matters, or at least used to matter. Needless to say, we're not traveling as much as we once did. Hopefully we'll get back to traveling, but who knows? Mostly, if you're going to get a urinary tract infection, particularly in women, the E. coli first colonizes your gut, and it lives there, and then it gets transferred across from the anus to the urinogenital tract. So it's worth looking, and I'll put the evidence behind this on the next slide. It's worth looking also at what sorts of E. coli are colonizing people's guts. And this study found 105 people in Sweden who were about to travel and got them to have a rectal swab before they traveled. One of them was already colonized by a multi-resistant E. coli with what I'll call an extended spectrum beta-lactamase, meaning an enzyme that can attack cephalosporins. Of the 105, 100, so also discounting this chappie this lady rather, who was already colonized, amazingly, 100, this is dedication, came back for a further rectal swab after their holidays. And by then, 24 were colonized with resistant E. coli, with extended spectrum beta-lactamases. That included 7 out of the 8 who went to India, and about a third of those who went to East Asia. And the type of ESBL you got depended on where you went. And 21 of the 24 had a further rectal swab at 6 months, and a quarter of them were still colonized. So prior antibiotics, a risk factor for resistant E. coli, and recent travel, a risk factor for gut colonization with a resistant E. coli, which matters for subsequent UTIs. as these data show. This was from Canada, right out in the Midwest, looking at infections with ESBL producing E. coli according to where people had been. And if they'd previously been to the Middle East, Europe, or India or Pakistan, where CTXM15 was the predominant ESBL, and then they got a UTI, well, often it was with a bug with CTXM15. If they'd been to East Asia, China or Thailand, where CTXM14 rather was predominant, that was the ESBL they got. And if it was the US, where at the time 10 ESBLs were prevalent, that was the ESBL they got. So you see, I hope the complexities that surveillance, as it's routinely done for UTIs, particularly in the community, is very distorted by sampling bias. Nonetheless, resistance matters, and the probability of resistance is affected by patient factors, recent treatment, recent travel. Another factor to consider here is strains of E. coli. Now, these are data from the UK. They're mixed dates, so you have to be a bit careful. Again, that's because the surveillance isn't very good. But you can serotype E. coli, but you can also do a sort of genetic fingerprint, which I've called the sequence type. And overall, there are many hundreds of different types of sequence types of E. coli described. But there's a few that are common. So let's start off looking at bacteremia. Remember, most bacteremias come from a prior UTI. In 2010 here, 116 isolates. 1, 2, 3, 4, 5, 6. 6 different sequence types accounted for almost 2/3 of all bacteremias. They also accounted for just under a half of all UTIs. So a very few strains, a very few sequence types of E. coli account for a lot of the problem that we see. ST131 deserves a particular mention because it's often an ESBL carrier and often fluoroquinolone resistant. And I've put the 2001 data in there solely to show you that it didn't used to be common in 2001, and it's gone up since then, whereas these others, 73, 95, 12, 127, 69, have been common causing UTIs or common causing bacteremias rather for a long time, and most of them, not 12, are also common in UTIs. 131 is often antibiotic resistant, often got ESBLs, often got fluoroquinolone resistant. But these other big ones from UTIs, 73, 95, 127, and 69, are not usually very resistant. Maybe they're trimethoprim resistant, maybe they're ampicillin resistant, but they're not commonly resistant to cephalosporins or to fluoroquinolones. So let's go back a moment. I said earlier, you should be looking to those antibiotics to which there's little resistance for treatment of these uncomplicated lower UTIs. And the ones that I could list from this study, and it's confirmed by many others, are Nitrofurantoin, Phosphomycin, Mesalinam. And if you look at UK or US guidelines, there's increasing advice to use these agents. The trouble is, all of them have limits. They're not really the best of agents. You know, if you go back to when trimethoprim or fluoroquinolones were active, well, they were active in ascending infection, they were broad spectrum, fluoroquinolones of themselves weren't affected by ESBLs, and they were efficacious if the patient was renally impaired. But these three agents that are keeping good microbiological activity against urinary E. coli, none of them is active if the infection has started to ascend. So be wary if the patient's showing any flank pain, fever, general symptoms of an ascending infection. Nitrofurantoin and phosphomycin, poorly active, or in phosphomycin's case, not active at all against other Enterobacteriales besides E. coli. And while E. coli causes 85% of infections, we can't dismiss Klebsiellas or Proteus. Between them, they probably cause 5 to 10%. These two are not beta-lactams. They're obviously not affected by extended spectrum beta-lactamases. There's differences of opinion on mesalinam. My view is that I would not trust it against any ESBL producer. Nitrofurantoin doesn't get into the urine very well if the patient has any degree of renal impairment. Now, for those of you in India and maybe Pakistan, you tell me, I'm not sure, there are further options, which I think are interesting ones. Oral cephalosporin combined with a beta-lactamase inhibitor, active against ascending infections, protected against ESBL. The problem is with these combinations that they've never been through proper clinical trials and they are not pharmacodynamically optimized. Often the amount of beta-lactamase inhibitor is too low. And then we've got farapenem, an oral penem, which is ESBL stable, again, without good UTI trials, and particularly a lack of evidence for ascending infection. These are being used in India, and I really would urge better clinical trials, and for these, for the inhibitor combinations, a thorough pharmacodynamic assessment of whether the appropriate amount of clavulanate is there. And I would encourage everybody to read this paper, which is very pertinent to these combinations. Now, you might say, well, what about phosphomycin compared with nitrofurantoin? And there's a paper here by Huttner, who did really a very good clinical trial, comparing the two head-to-head, 3 centres, 3 countries, randomized clinical trial, nitrofurantoin for 5 days or single dose phosphomycin. And in terms of clinical cure particularly, but also microbiological response, it came out in nitrofurantoin's favour. That surprised me. I would have thought phosphomycin would at least be equal, but you cannot argue with data of this quality. Nitrofurantoin came out the better of the two. That said, possibly a 2-dose phosphomycin regimen, which would be used in many countries, would have been better. But let's now go back to that issue of the bacteremias that are seeded by UTIs. And in the UK, we very much switched from using trimethoprim to nitrofurantoin. This is expressed in a very complicated way as trimethoprim as the proportion of trimethoprim plus nitrofurantoin for treatment of UTIs. So as the red line goes down, that's use of trimethoprim. What it means is that as the mirror image of that, nitrofurantoin must be going up. So we've swapped from treating UTIs in the community with trimethoprim to treating them with nitrofurantoin. Across a period, look at this, 2017, 18, 19, pick up the same period here when the role of E. coli in bacteremia has continued to increase. So this notion that we would do better at treating UTIs with with nitrofurantoin and bring the total bacteremias down hasn't worked as yet. Maybe give it time, but of course now we face the great disruption that COVID has given. Now, you're from a variety of countries. You can take your own view on whether and how COVID has disrupted primary and other healthcare in your countries. It's not for me to say. But in the UK, it's been made dramatically difficult to see a general practitioner. There's been a massive shift from face-to-face consultations, including no doubt for UTIs, to telephone consultations. And the cartoon just shows a very well-defended general practice with this poor unfortunate old lady who may well have a UTI, wondering how to get through the barbed wire. Not just us, this is Denmark, 2010 attendance, unplanned hospital attendances, so emergency room, which would include presentations for acute UTIs and particularly acute ascending UTIs. Look what happens when lockdowns, shelter at home comes into place, comparing 2020 with earlier years. Numbers of people presenting to emergency rooms, including no doubt with UTIs, drops dramatically. And look now at our bacteremia data, E. coli bacteremias again. And this time I've split this, instead of smoothing the line to give annual data, I've put it as quarterly. And you'll note we always get a summer peak for E. coli UTIs, as E. coli bacteremias, forgive me. Nobody's quite explained that. Some people think it's because more patients are dehydrated in the summer. That prompts UTIs, which then seed the bacteremias. But then look at 2019 to corresponding quarter in 2020. The circles are the same color. So this is quarter one, quarter two, 2019 to quarter two, 2020, quarter three, 2019, pre-pandemic to pandemic. Numbers of E. coli bacteremias seem to have gone down, but the hospital onset ones haven't. The community onset ones that are going down. And I don't believe this is anything to do with a real diminution of UTIs and contingent bacteremias. I think this is people who were frightened to go to hospitals or unable to go to hospitals. And I believe these data are reflected here in disruption of healthcare and rising numbers of deaths in the community and in care homes. And if you look at this, all these rows here are the grey dot is the average number of deaths 2015 to 2019. The blue dot is 2020. So the difference between the two is excess deaths. And in 2020, 41,000 excess deaths at home. Only 3,000 of those due directly to COVID-19. And there's a lot of these excess deaths are cardiac, dementia, though we know that dementia of itself isn't what kills people, I believe that hidden somewhere in that are people who had E. coli bacteremias and never got to a hospital. I cannot prove it, but I think as finally the effects and the collateral effects of the pandemic are teased out, we will see that. Certainly COVID has disrupted healthcare worldwide, massive numbers of postponed surgeries, massive numbers, or massive growth of hospital waiting lists. And whatever happens with COVID in the future, with vaccinations and whatever degree we manage to suppress it, we have to accept we faced an altered medical landscape. And the more we can do to keep patients out of hospital, the better. It reduces pressure on hospitals, and we also know that hospitals have been great places for the transmission of COVID. So we want to maximize cures in the community, and that includes stopping UTIs from going on to be from uncomplicated to complicated to precipitating bacteremias. So we need, I think, to achieve that several things. We need to better understand UTIs in the community in order to treat them well. And that means we need better surveillance, including much better stratification and knowledge of patient types. Is this lady likely to have a resistant strain causing her UTI, or has she not travelled, not had recent antibiotics? Not very likely to have a resistant strain. Better algorithms to predict resistance. Beyond that, for the future, we need rapid tests and molecular tests done directly at the general practitioner's office to detect infection and to predict whether the infection is likely to be resistant. You could do that either by looking for resistant genes, or you can do it looking simply for sequence type 131, which accounts for a huge amount of resistance. We need new agents which are oral and are effective in ascending infection. And there are two now licensed or in advanced trials in the United States, sulopenem and tebipenem. There are further trials ongoing with these sorts of combinations, which have so far only been available in India, of oral cephalosporin with an inhibitor, perhaps better pharmacodynamic optimization than previously. And Glaxo has got a drug, gepotidacin, which I always have difficulty pronouncing, gepotidacin or gepotidacin, I'm not sure which it should be even now. It works on the same target as fluoroquinolones, but it works differently, so there isn't cross-resistance. So, ladies and gentlemen, I've said quite enough. I've talked on for about 35 minutes, left is 15 for questions. I started off making the point that UTIs are extremely common. Most of them are trivial and self-limiting, but a few seed much more serious infections. And because of the numbers, these UTI-seeded E. coli bacteremias are actually a very considerable slice, about a third of all bacteremia. And while we have good surveillance in many countries of the bacteremias, we have very poor surveillance of the UTIs that seed them. The samples from UTIs that go through laboratories are biased, and we know that some patients are much more likely to have a resistant UTI than others from their travel, from their recent medical history. The drugs that we're increasingly pushed to use because of resistance to better agents, the drugs that we're increasingly pressed to use, phosphomycin, nitrofurantoin, mesalinam, have considerable limitations and are apt to fail if infection has become ascending. New combinations may be on the way. Hopefully they will be, but we need to use them carefully. COVID has, in every country and in subtly different ways, caused massive disruption of healthcare, and that includes for UTIs. I believe, but cannot yet prove, that it's actually displaced some of the E. coli bacteremia community out of the hospitals into the community. In any event, making it harder for patients to see a general practitioner, makes it harder for them to get good treatment for any illness, including a UTI. But we must find ways to improve things, to treat patients well, and to identify who does and who doesn't need one of these newer agents that may now be on the way. Thank you.
Thank you so much, sir. That was an absolutely phenomenal talk by Professor David Livermore. Hearing your talk, sir, elevated our understanding and appreciation of troubles with simple community-acquired UTI to a different plane altogether. And I'm very happy that we have many of our clinical colleagues here, and that's the entire main aim of the study, is that we work together so that they appreciate our problem and we appreciate their problem, and together we can cobble together a study which does appropriate surveillance and comes up with appropriate antibiograms, which will then appropriately help in management of our patients. It was akin to standing on the shoulders of a giant, sir. A big strength of our study is the mentoring we will be receiving, as we have, from Dr. Livermore. And the first year of our study is exactly on what Dr. Livermore has talked about, that is community-acquired UTI, and where we need to really focus and get those samples and identify the resistance profile, and then, of course, tailor the study. We stand truly elevated and inspired. I would just like to add that we are a no-fund study, but with superlative mentoring like today's, I think we are richly funded indeed. Thank you so much, sir. Now, coming to the question. Thank you. It was absolutely splendid. And I'm sure everybody is, I'm just echoing everybody else's thoughts here. One of our esteemed teachers, Dr. N.P. Singh, is here, and I'm very thankful that he is. And he has also thanked you for giving us this great talk. He wants to know whether the gut E. coli serotype is the same as that seen in the strains causing UTI. That is one question. And is the same clonality seen in the bacteremia? I mean, the UTI, for example, if it's ST131, are we seeing the same ST131 or whatever ST type in the bacteremias?
So, I mean, there's a lot of factors there. I mean, certainly we see a number of sequence types, 131, 95, 63, 127, 12, which are good at colonizing the gut and which are important in UTIs and bacteremias. And the slide had the details up earlier. There are other E. coli which are good at living in the gut and do so entirely harmlessly, and are no doubt an important part of the gut flora, but which don't have that ability to give UTIs. As the slide showed, there's a considerable overlap between the types that give UTIs and bacteremias. There are a few, though, which can give a UTI and are not good at invading into the bloodstream. 131, I think, is important because, one, it can live in the gut perfectly happily. 2, it can give UTIs. 3, because it's often antibiotic resistance, there are treatment failures and overspill into the bloodstream.
True. So that's one aspect which I think Dr. N.P. Singh would like to do on our own as well. We take our ESBL E. coli and correlate with the bacteremia and see what's really coming up. I mean, that'll be an interesting study in our end as well. Dr. Kara from PGI Chandigarh wants to know, it's a good question again, with asymptomatic bacteriuria, I think she means, are there different strains causing such growth without any symptoms?
Very good question. I mean, the rule of thumb is asymptomatic bacteriuria, you do not treat. So long as the patient is not unwell, you've got a few bacteria, commonly in old ladies' urine, it doesn't need to be treated. But I'm not aware of any good study of surveillance of what types of E. coli are present there. Okay. That would actually be a very, very interesting study to do. I would encourage it. Do a good literature search first, just to make sure somebody hasn't done it. But if they have, forgive my ignorance, I'm unaware of it. But if they haven't, it would be a damn good study to do.
Yeah, really, really, Dr. Kara, that was a good question, really. We have Dr. Sumit Rai, one of our guests here. He is asking, does Quick screening kit fare in accuracy and rapidity in diagnosis? It's a light scattering technology applied to urine culture.
Yeah, forgive me, I don't know the answer to that one. I would have to look at what's published there. It's not a test I've ever used.
That's absolutely fine, sir, because anyway, in our centers, we don't have this kind of technology, and the strength of a study or feature of a study is that we are no funds. We are very standard medical colleges or private sector, which has, the basic standard facilities. So we're working with our strengths, and we want to improve the efficiency of our reporting, of our clinical colleagues and ours. So that's where the diagnostic and antimicrobial stewardship will focus on.
I think one thing that COVID has done, one positive that's come out of COVID, is the development of all sorts of rapid tests and lateral flow tests in particular, which can be used in the community. Now, they have lots of imperfections, the lateral flow tests, but suppose we could get a lateral flow test which looked for E. coli and looked specifically for sequence type 131 in somebody's urine. So you've got clinical signs and symptoms of a UTI, fine, tick. Test 1, is it E. coli there? Yes. Test 2, is it E. coli? Test 3, is it sequence type 131? If you could do those 3 tests quickly at a pharmacy, then I think that would give a very good guide to what sort of antibiotic the patient would benefit from. And that lateral flow technology may well be applicable there.
Yeah, true. So one of 2 questions from me, as you yourself noted that we in India have a gamut of interesting combinations with, the inhibitors, beta-lactam inhibitors. So what is stopping UK from, for example, using cefoperazone sulbactam, which is an excellent buffer drug? So before we rush to piperacillin tazobactam for mild and moderate, we use cefoperazone sulbactam, which I feel has a great role to play. The same issue, of course, we see in Oman. We don't have that drug here. So what is your reason? Why do you think it's not available in the West?
I can tell you exactly the history with cefoperazone sulbactam was that if you go right back to the 1990s when Pfizer were developing it, they went to the American Food and Drug Administration, who smiled very nicely and said, you must do a trial compared with cefoperazone itself, which was then on the market, to show that that the sulbactam is achieving something. And Pfizer then turned around and said, no, we're not going to do that trial. So it was never licensed in the United States. And equally, they never pursued a license in Europe or the UK. They did license in numerous Asian and I think Latin American countries as well that didn't make this demand on them. I mean, my view would be that sulbactam is really the weakest of the beta-lactamase inhibitors. Nonetheless, cefoperazone is a relatively easy antibiotic to protect, and clearly it's well spoken of by many physicians who use it. It has some merit. It isn't desperately underdosed. I mean, if I look to the Indian situation, and this is really going away from UTIs now into more severe infections and bacteremias, cefepime tazobactam I think is a very interesting combination.
Yes.
Unfortunately, what has happened in India is that the companies that have developed this have kept the 8:1 ratio that you have in piperacillin tazobactam for cefepime tazobactam, which means that if you're giving the patient pip-tazo, you're typically giving them what, about 2 grams per day of tazobactam, if it's 4 plus 0.5 4 times a day. On the other hand, if you're giving them cefepime tazobactam, let's say 2 grams plus 0.25 grams 3 times a day, you're only giving them 750 milligrams per day of tazobactam. So you're only giving them 37% of the tazobactam that they would be getting if they were on pip-tazo, which, although cefepime is easy to protect, that's not enough to protect it well. Wockhardt are developing a high-dose cefepime tazobactam, which may well be better.
8:8. What would you say? 8:8 would be a better combination?
Well, I would have thought that for cefepime, 2 grams cefepime plus 1 or 2 grams tazobactam per day is the right way to go, because then you're getting that high dosage of beta-lactamase inhibitor, which is sufficient to deal with hospital bugs, which have often got very large amounts of multiple beta-lactamases. But at this point, we're straying away from UTIs into hospital medicine.
But the issues which concern us, because what happens is, I have this grouse with the West when they say, ESBL and go rush to carbapenems, which in India, we're notorious for overusing our drugs. But one very good thing which happened in India, because maybe with the economies, we can't afford carbapenems for our poor patients. So we would go to cefoperazone sulbactam, then proceed to piperacillin tazobactam, and as a last resort. So I feel personally that we saved carbapenem, although of course it doesn't look like that.
I have a lot of sympathy with your point of view there. I think it should have been made a lot easier to license combinations of old beta-lactam with old beta-lactamase inhibitor than it has been. I do, however, think and India has done better at that. The problem has been that often the combinations have been suboptimal in terms of the amount of inhibitor. So it needs much better pharmacodynamic modeling to support it. But the principle is right. And I mean, we also now have the absurdity looking at new antibiotics that as trienam with avibactam, which is more pertinent to the Middle East and India with a lot of NDM carbapenemases than is ceftazidime avibactam, which doesn't cover NDM, is lagging about 5 years behind. And this is crazy when avibactam is now a well-established beta-lactamase inhibitor. It's clearly safe. As trienam and ceftazidime clearly are long-used antibiotics.
Yes. Another question, sir, which I'm troubling, not really troubling, but I need to learn from you, is again with AMC producers. We say now the drug of resort, last resort goes to carbapenem. But now what we did was some in vitro synergy testing. And we found very interesting results with piperacillin tazobactam, with levoflox, or with amikacin. And I personally feel that we could do those kind of studies in the microbiology lab and still try to, promote carbapenem sparing protocols. What is your opinion about that?
Well, I would be wary on that. I don't really trust pip-tazo against ESBL producers in severe infections.
Synergy, sir. Synergy with levo or synergy with amica.
No, if you take sequence type 131's E. coli's, you've got so much Cipro resistance. If it's a UTI if it's still susceptible to amikacin, even if there's a bit of overspill into the bacteria, into the bloodstream, you may get away with it. But you know, from David Patterson's Merino study, I'm very wary. Whereas I would be positive on the cefepime tazobactam if one can get to that high dosage of tazobactam.
Yeah, but yeah, the cost is the limiting factor there, sir. But you know, I would like to share with you amikacin, where we found high MICs of amikacin and seriously ill patients, and we actually saw synergy with levo and amica as well. Of course, we did not know the ST131 way. We did not know the and I hope it's not as prominent in India as it is said to be. But amikacin definitely is a hero, is an unsung hero, and I think we could work with that at least.
I think, you know, aminoglycosides in a complicated UTI against a susceptible strain, there is no doubt. Aminoglycosides are very effective antibiotics. I am much warier about depending on them in a bacteremia, say, particularly if it's a non-urinary source, if they're together with another drug that's not active on its own account. And synergy, yes, synergy exists, but it's so dreadfully hard to measure accurately.
True.
You must forgive me, incidentally. We're going to have to drop off in a couple of minutes because we are. I have a train.
That is so exciting, sir. I'm sorry, we just got
carried
away.
So we have a couple. If there's another couple of really good questions there, let's have a go.
Yes. Let me just see. Dr. Sumit Rai is saying it's a 2020 guidance document specifies only carbapenems for ESBLs as monotherapy. And I agree with Dr. Sumit that I just don't agree with that. I mean, I think is it the consumers which are pushing us to use higher end antibiotics? What is happening? It's not good microbiology.
I think a lot of this comes from the Merino studies results, which are pretty unarguable, that in a severe infection, and we'll get again, we were way here from UTIs per se, that they strongly favour meropenem, and that study was set up by people who were hoping to show that the alternatives were as good. But I think also you have very much to look at your patient, your type of infection, and ask yourself if there are reasonable alternatives. Would we perhaps do better to use in relatively mild, complicated intra-abdominal infections, appendicitis and so on? Would we do better to use a lot more tigecycline and take pressure off beta-lactams generally? I've talked about phosphomycin and nitrofurantoin this morning, and while I've shown some caution on them because of their limitations, it's fair to say that they have very unlinked resistance to other antibiotics. So the more we can use them for genuinely uncomplicated UTIs and no-risk patients in the community, that is good stewardship.
Yes. And thank you for giving us that excellent guidance. And thank you. And I'm so happy that we have so many of our leads and clinical leads with us, because that's exactly what we need. We need to be more custodians of antibiotics. That's not just the microbiologists. We need to be very, very intelligent about it. And the direction has been given very, very well by Dr. David Livermore. And thank you so much for that. I'd just like to conclude by saying that the bugs are very generous creatures. They share the resistance far and wide, within the species, outside the species, without batting an eye. This study aims to take a leaf out of their book. We will collaborate extensively, share our strengths generously, and I hope we emulate and follow what Dr. David Livermore has told us. We will mentor each other and build effective systems to combat AMR. Dr. David Livermore, by so generously sharing your extensive knowledge and giving us the guidance on how we should proceed with this study, I am deeply indebted to you. You have kickstarted us in the right direction, and I can't tell you how well this has been taken by all of us. Thank you so much, sir.
Absolute pleasure. Okay, thank you.
Thank you so much, all the valuable leads and the great audience. You were absolutely awesome. If the esteemed leads would stay back for a few moments, it would be lovely. Thank you so much, sir, for that awesome talk and for getting us together at such a nice platform and giving us that wonderful guidance. Thank
My
you.
pleasure.
Thank you so much, sir.
Okay, cheers. Bye.
Okay, have a good day, and sorry for
Thank
troubling you early in the morning.
No, not at all. My pleasure. Not early.
And lots of regards to your wife, sir. Thank you, everyone. It was absolutely splendid being with all of you.
May I can I
Yes.
just interrupt? Would you
Yes,
like me to
please.
stop? Would you like me to stop
I think that
the
would be-
recording?
Yes, yes. Please, please.
Okay,
please.
so I'm going to
That'll
stop
be
the
great.
recording now. Okay.
Thank you. Thank you. Thank you.